Come in.
Hi, Miss Johnson. My name is Stephanie. I'm going to be your nurse for today. How are you doing?
Great.
Can you please verify for me your full name and date of birth?
Blair Johnson, 7/11/1963.
Perfect. Okay, Miss Johnson, so I'm here to check on your chest tube drainage, okay? Are you currently feeling any pain, discomfort? No.
No.
So at this time, at this point of the checkup or of the procedure, what I'll be doing, I'll be assessing my patient from head to toe. I'll be assessing for the especially vital signs, blood pressure, respirations, heart rate, and if there's any pain. Also, by this time I'm gonna after I assess all that, I'm gonna go to the area of the chest tube. I'm gonna go ahead and remove. I should have a 4x4 gauze. I'm gonna go ahead and remove it. Okay, Miss Johnson, I'm gonna go ahead and remove this dressing real quick, okay? So I'm gonna remove. For inspection, what I'm looking for is to make sure there's no drainage. And I'm also gonna be looking at the mark of the tubing, which it should be at 8 centimeters. We need to make sure that there's 6 dispensers, like ports. We need to make sure they're all in, because if not, there may be an air leak. Okay, after seeing that, okay. And then we'll also check for any redness, swelling, or any signs of infection to that area. After that, I'm gonna be like, okay, everything's fine. Then I'm gonna go ahead and the drainage, we're dealing with the ocean, which is the water sealed suction. It's the blue one, and it needs to be on the floor at all times. But for video purposes, we have it up here. So we're gonna be checking that there's no air leak. By doing that, what we do is that we're gonna, if there will be an air leak, we will be seeing it on the C chamber. This one we expect to see gentle bubbling, but that will be on the A chamber. And if there is any air leak, we'll see it here. So right now, let's pretend I do see there is an air leak, so something is going on there. For this, what I have to do is I have to go ahead, I'm gonna need some hemostats. I don't have hemostats, but I'll pretend my fingers are the hemostats. So for this, I am gonna start on the proximal end of the patient, which will be this, and then I'll be working my way up, down. So I'm gonna start by clamping here, and then I should be observing the C air chamber and make sure bubbling stops. If it doesn't stop, I go clamp here, unclamp, and then if it doesn't stop, like that, and keep going down. And let's say it stops here, that means the air leak is coming from right here. At the moment, I unclap my patient, and I need to make sure I do call the MD the doctor immediately. So
Do you leave your patient?
I do not leave my patient alone at any time. And that will be for troubleshooting. That will be in the assessment if we're assessing our patient that already has the system in place. Let's say it's not, and we need to connect the chamber from the beginning. What we will be doing is that this will not be connected yet, and we need to fill in the A chamber with the normal saline. So it usually has a clamp here, a little port
Stopper.
that you open, and you pour the water. The water should be going to, you should fill it in with 30 cc's, which should mark the 2 centimeter mark. And then by this time, you need to make sure that the first thing you do is to connect the patient. You're first gonna connect the longer tubing, which is the patient. And then after that, you are gonna connect the suctioning after that. The suctioning, it doesn't have on the wall, you just go by the green, yellow, or red. It doesn't have any specific number that it should be to, but the water on the chamber equals the pressure of the suction. You do need to you need to have in consideration that there are some complications that might happen. One of them will be, of course, how we said that air leak. That's one of the main complications, and as I already stated, that's what we should have done. Another complication will be the tension pneumothorax. Tension pneumothorax would have happened, for example, when I was troubleshooting and I would have left the clamping. That would cause a tension pneumothorax. Also, another complication could be if the patient gets disconnected, because sometimes patients are conscious and they turn on their own, or when they're getting transported, they forget to disconnect the suctioning, and it pulls, and it will pull it from here, which it will be the one where it's the connection. If this happens, I mean I can't show it because it's not a real chest tube, but we will be disconnecting them, and we need to make sure we put in a water seal immediately. If you don't have a water basin, then you should put in your NS bottle to prevent any air from going in there. So we need to make sure, as I said at the beginning of the video, it has to have the 4 tapes if it's in place. Let's say another complication will be if this gets dislodged from the patient. You need to make sure you immediately put a gauze, you put pressure, and you only take 3 sides. For the tension pneumothorax, you need to make sure to identify it. You will be identified with tachypnea, dyspnea, pain, shortness of breath, and tachycardia. You can also see clots in the tubing. At this time, it is most likely they're gonna ask you to change your device, because that one can also cause a pneumothorax. In case a pneumothorax happens, it's immediately you do call rapid response, and you need to set up for a needle decompression. What else? For a tension pneumothorax, you need to keep in mind that a really late sign, it's deviated trachea. And usually, if it's more deviated to the right, that means to the right, that means your left lung is the one that it's affected, and vice versa. What else? So for this one, I kind of explained already what the A chamber and the C chamber is. So we also have on the other side, we have our Oasis one. This one is our dry suction. For this one, our dry suction, it is really unique because it is usually used for traumas. Reason being is that because the settings for the pressure goes up to -40. On this one, it is really important to keep an eye on the E chamber, which is an orange accordion. that will go raise up the arrow, and that one is indicating that the device it is working. So we need to make sure we keep an eye on that one. This one requires, this is on negative control also, and this one also requires the water to be filled on the B chamber. This one usually comes with a pre-filled syringe, and you will invert the syringe. On the top you have a blue entrance, which is a connector. You invert it and you put it in there. It's usually 40 cc's if I'm not mistaken. Yes, it's 40 cc's that it's gonna go in, which needs to reach the mark of 2 centimeters as well. And then this one doesn't have a stopcock. And that is pretty much it. Thank you.